All right, let's talk about urticaria. We've all been there, right? It's one of those conditions that can be just incredibly frustrating, not only for our patients, but for us too. So this explainer is really designed to be a focused masterclass to help us sharpen our clinical skills and really nail the diagnosis and treatment.
So here's how we're going to break this down. We're going to walk through it just like a case in the clinic. First, what are we actually seeing? Then, why is it happening? How do we organize and classify it? How do we nail down the diagnosis? And finally, what's our step-by-step game plan for treatment?
First things first, it all starts with what you see right in front of you. Before we dive into the deep science or treatment algorithms, we have to be absolute experts at recognizing the fundamental lesions. You know, getting this right at the beginning saves a ton of headaches down the road.
So you've got two main players here, the wheal and angioedema, and they're totally different. The wheal or rhoncha, that's what your patient calls hives. They're superficial, intensely itchy, and, this is key, they move around. They're there in one spot in the morning, gone by the afternoon. Angioedema, on the other hand, is a whole different animal. It's that deep, puffy swelling, often more painful than itchy, and it sticks around for a couple of days.
Okay, if you remember one thing, let it be this. Always ask your patient, how long does one single spot last? Seriously, if they tell you it lasts more than 24 hours or if it leaves behind a bruise or a mark, then you have to pause. Your diagnosis of simple urticaria might be wrong, and you've got to start thinking about mimics, especially things like urticarial vasculitis.
So now that we know what we're looking at, let's pop the hood and see what's really driving this. Understanding the nuts and bolts of the pathogenesis isn't just for exams anymore. It directly explains why our new treatments, especially the biologics, work so darn well. You know, for all its different forms and triggers, urticaria really boils down to the bad behavior of one key player, the mast cell. That's our target. Doesn't matter if it's chronic, acute, spontaneous, or triggered by cold, this cell is always at the scene of the crime.
And what happens is this incredibly fast and dramatic cascade. Some kind of trigger, it could be an antibody, it could be physical pressure, whatever. It basically flips a switch on the mast cell. The cell then degranulates, which is a fancy way of saying it just dumps its entire payload of inflammatory chemicals right into the skin. And the result? The wheal you see on the surface just minutes later.
And here is that inflammatory cocktail. Of course, we all focus on histamine, and for good reason. It's what causes most of the itch and swelling. It's why antihistamines are our first-line treatment. But don't forget the rest of this crew. These other mediators like leukotrienes and prostaglandins help explain why some of our patients just don't get full relief, even when we push the antihistamine doses way up.
Okay, great. We've got the what and the why. Now we need a practical way to organize all this in the clinic. A framework that actually guides what we do next. And that starts with a good, simple classification system.
The very first fork in the road is time, and that 6-week mark is everything. It's not just some random number. Acute urticaria, lasting less than 6 weeks, is usually a one-off thing, often tied to a virus or a drug. But chronic urticaria, that's a completely different disease. It means we're in it for the long haul, and that requires a totally different conversation with our patient. Now, if we zoom in on just the chronic cases, this breakdown is so important. Look at that. 3/4 of them are spontaneous. This is a game changer for how you talk to patients. It means for most people with chronic hives, that frantic search for some external allergy trigger, it's probably not going to lead anywhere. The problem is coming from the inside. And if we dig even deeper into those spontaneous cases, we find this. It's fascinating. We used to just call it all idiopathic. But now we know that nearly half of these patients have a clear autoimmune basis for their disease. Realizing this is what gives us the confidence to escalate to therapies that target the immune system. We're not just throwing darts, we're treating a known mechanism. Which brings us right to the diagnostic workup. So, how do we get to the right diagnosis efficiently without ordering $1 million workup on every single patient who walks through the door?
This is the key question we should be asking ourselves. And the short answer is, we only do extensive tests when the patient's story points us in a specific direction or raises a red flag. Our workup needs to be driven by a hypothesis, not just a checklist.
And this really says it all. You know, in this age of high-tech medicine, urticaria is still a diagnosis you make with your ears. The patient's story is what gives you your clues. The lab tests are just there to confirm what you already suspect.
So when you're taking that history, you have to be a detective. There are 2 areas that are absolute gold. First, ask obsessively about triggers. Go through the list: pressure, cold, heat, sun, vibration, exercise. That's how you uncover the inducible types. And second, find out exactly what they've tried before and how they responded.
A patient who's already failed 4 different antihistamines at high doses is telling you a very different story than someone who's never tried anything.
And here it is again, probably the most high-yield question in your entire workup. If I could only ask one thing, it would be this. How long does one individual hive last? If they say it sticks around for more than a day, and especially if it leaves a mark, that should set off major alarm bells for urticarial vasculitis, and that patient needs a biopsy, period.
All right, let's bring it all home and talk about treatment. Our approach today is a clear, stepwise strategy. And let's be clear about the goal. It's not just to make patients a little better. The international guidelines say the goal is complete control, 0 itch, 0 hives. Before we even think about a prescription, we have to lay this groundwork. Patient education is not a soft skill here. It is a critical part of management. Helping patients understand their disease and avoid things that are known to make it worse, like NSAIDs for some people with CSU, can make a huge difference in how well they respond to whatever else we do.
The treatment algorithm from the global guidelines is super clear and evidence-based. We start with our safest and most targeted therapy, second-generation H1 antihistamines, and we're not shy about the dose. We push it up to 4 times the standard dose if needed. If they're still breaking through, that's our cue to move to step 2, adding on a biologic like omalizumab. Cyclosporin is really a third-line option, save for our toughest, often autoimmune cases.
These are our workhorses, our first-line agents. We need to be comfortable using all of them. And here's a little clinical pearl. If a patient says one of them didn't work, it's definitely worth trying a different one before you give up on the whole class. Even though they're similar, you'd be surprised how much individual responses can vary.
So that leaves us with one final thought. Our therapies, especially the biologics, are getting so good at controlling the symptoms, at putting out the fire. But the next big question, the next frontier, is can we move beyond just suppression? Can we actually figure out how to modify the disease itself, to induce a real, lasting remission even after they stop the therapy? That, right there, is the future of what we do.